I'd like to call the House Health Full Committee meeting to order. Will the clerk please take the roll?
Representatives Boyd, Carringer, Clemens, Faison, Farmer, Gillespie, Hakeem, Hawk, Haynes, Hemmer, Hicks of Hawkins, Hicks of Washington, Jernigan, Kumar, Martin, Mitchell, Rudder, Sherrill, Travis, Vaughn, Whitson, Williams, Vice Chairman Leatherwood, Chairman Terry. Mr. Chairman, you have a quorum.
All right, thank you. And before we get started today, do any of the members have any personal orders? Okay, seeing none, we have TennCare that will be presenting their budget today. And so with that, I'd like to go out of session, invite TennCare up here. Director Smith, you are recognized. I think you know how this goes.
Thank you very much, Mr. Chairman and members. It's a privilege to be with you all this afternoon. My name is Stephen Smith. I serve as the TennCare Director. With me today, to my right is Zane Seals, our Chief Financial Officer, and then to my left, Dr. Victor Wu, our Chief Medical Officer, and Kim Hagan, our Director of Member Services. Mr. Chairman, about a year ago today, I sat before you in this committee in this same spot, and I expressed my optimism about both the present and the future of TennCare. And today I can say without hesitation that this optimism is greater than it has ever been. And that is because of the leadership of our governor, the General Assembly, this committee, the men and women who have chosen to call TennCare their work home, and the tireless efforts of our partners and providers who wake up every day to serve our state and the Tennesseans who rely on TennCare for assistance. I plan to move through this presentation at a steady pace in order to get to your questions and your comments. But if you hear nothing else from me today, I hope that you will hear and that you will see that TennCare has never been in a stronger position than it is today. We've never been more successful than we are today. And perhaps the greatest evidence of that success is the negotiation and implementation of our TennCare 3 waiver and the shared savings reward that we have now secured and that the governor announced in his State of the State address. This is the culmination of more than 2 decades of hard work, trial and error, innovation, restraint, and partnership between multiple administrations and multiple General Assemblies. And we remain very thankful for that continued partnership, because the reality is, just because we've reached this level of success, it's not a guarantee that we're going to stay here. We must continue to do the things that got us to this point. We must continue to seek improvement and push for responsible, innovative, and efficient management of our program, because that is our charge and because the state's success depends upon it. Our mission at TennCare is simple in words, but it's complex in action. That mission is to improve lives through high-quality, cost-effective care. And while, of course, our focus is on improving the lives of TennCare members, the work is actually much bigger than that. And we view our role as one where we can positively impact the lives of Tennesseans in all walks of life, not just the Medicaid population. Now, some may hear that and think that's a bit of a stretch, but when you consider the size of the TennCare budget and the impact that our budget has on the overall state budget, and therefore all of the other policy goals of our state and all the things that you care about as policymakers, our responsibility becomes much more clear. TennCare does impact our state's ability to deliver quality public education. TennCare does impact our state's ability to make improvements in criminal justice, public safety, infrastructure, economic development. And TennCare does impact the state's ability to keep taxes and debt low in a state where our people demand and expect it. We have to be successful in our efforts, or we simply lose ground as a state. And part of our job, I believe, is to do our part so that people never need Medicaid in the first place. And this is a recognition and a responsibility that we take very seriously. And while we face criticism at times for that cost-effective piece of our mission, it's actually this very piece that allows us to improve quality, access, provider support, and health outcomes within TennCare, and to do so without breaking the state budget. And this budget piece it's a very real concern. We've come a long way in our TennCare program, but it really wasn't that long ago when double-digit growth trends and runaway costs threatened the very existence of TennCare, at least TennCare as we know it. In fact, in the early 2000s, projections showed that the TennCare budget was literally going to take every available new state revenue dollar in just a few short years. Clearly, that was not sustainable. And so the executive and legislative branches at the time worked together, and they took major steps in 2004 to reform the program. And some of those steps were very painful, and some of you remember that well. And no one wants to be in that position again. But that history is important because it plays a large role in decisions that we make even today. This committee is well aware of this, but TennCare makes up a very large portion of our state budget, and we're more than $14 billion now. What that means then is that if we are unable to control costs to a reasonable level, there won't be any funds left over for other state priorities. And there certainly won't be any funds left over for the types of TennCare improvements that we've seen in recent years, which are unprecedented. So while it may seem counterintuitive, that cost-effective piece of our mission means that we can do more to further the priorities of state government, both inside and outside of health and healthcare. And by that measure, we have been extremely successful in Tennessee. Since the year 2000, Tennessee has outperformed every single state in the country when it comes to limiting the growth of the share of the state budget supporting Medicaid. And this translates into real dollars and real people. And I'll give you a very tangible illustration. If our trend rate had simply been at the national Medicaid average since 2012, we would have spent an additional $5 billion in cumulative state funding to run our program. And today, our budget would be $1 billion more in state dollars. It just so happens that last year, our state made a record public investment in public education of $1 billion. It's a truly incredible amount. But that investment is simply not possible without the work and the choices that we have made in TennCare. But perhaps more relevant to this discussion on the budget, the reality is that we simply would not and could not accept spending an additional $5 billion of state dollars on Medicaid at the expense of all the other needs of state government. So that means one of two things would have to happen. One, higher taxes for our citizens to fund all of the people and the services that we currently provide in TennCare, or two, cuts to the TennCare roles or services or provider rates. So the point there is that the cost of TennCare being average is real. We don't have the luxury of being average. And that's especially true in this time of very high inflation, which TennCare is certainly not immune from, and which we'll talk about a little bit later. We can be proud as a state that we've avoided those reductions, and we've done it through sound fiscal management, that cost-effective piece. But it's important for me to stress that we have not done that on the backs of access or quality. In fact, it's the exact opposite. We've increased access and we've made great strides on quality. By any measure, we've seen marked improvement on quality and health outcomes within the TennCare program. The HEDIS measures provide a great example of that. HEDIS stands for the Healthcare Effectiveness Data and Information Set. It's one of the most used and validated healthcare measurements that tracks healthcare quality and outcomes. There are about 150 of these measures, and TennCare's outcomes were better than the national average in nearly 60% of those measures. Now, I'm not suggesting that we deserve a party for that percentage, but compare that to 2010, when our outcomes were better than the national average in only 40% of those measures. So we have made considerable progress over the last decade when it comes to quality. Also, when we think about quality, we think it's important to ask the very people that you are serving how they view the benefits, how they view their access to care. Every year, the University of Tennessee conducts a survey. It's an independent survey, and they gauge member satisfaction with TennCare. This year, we had our highest rating ever at 95% satisfaction, and that caps a string of more than 10 years at above 90%. Moving specifically to the FY24 budget, I want to lead with our TennCare 3 waiver because it's so essential to the recent improvements that we have made and the items that we are proposing in the FY24 budget. So despite what some believe, we've been operating under this waiver now for 2 years. And as a reminder, the core principle of this waiver is that Tennessee will have the opportunity to be rewarded for our effective management of the program through additional federal dollars that are referred to as shared savings. And then we reinvest those funds back into the program in a manner that will benefit our TennCare members. As we have said all along, the TennCare 3, this waiver, it's about more. It's certainly not about less. Contrary to what some critics predicted, since the implementation of the waiver, we have made unprecedented increased investments in TennCare. We've enhanced benefits and services, and we have added more people in need. Examples of this include, for the first time, we are providing a comprehensive adult dental benefit. That kicked off on January 1st of this year, and in just 6 short weeks, we have served 8,500 adults. We are serving thousands of additional people with intellectual and developmental disabilities. These were individuals that were on a waiting list for our Employment and Community First Choices program. We're serving an additional 2,000 people. We're providing 12 months of postpartum coverage to mothers that we're currently doing that through a pilot. We've made workforce investments in behavioral health, dental, and home and community-based services. And then we provided additional supports for public hospitals. And all of that is with your support and your action, and we're very appreciative of that. We were able to make those investments because of our confidence in our waiver. We essentially bet on ourselves, but we did so through a strong negotiation and a commitment to agree to a deal only if we knew that it would be good for Tennessee. So this is a deal that, coupled with our collective efforts, has now resulted in a first-year shared savings of more than $300 million that we are now proposing to do exactly what we said we were going to do: enhance benefits and, yes, expand coverage to more people in need. And here's the kicker. Having the shared savings allows us to do all of these things without any additional burden on the Tennessee taxpayer. Today, I'm really excited to outline our components of the Governor's Strong Families Initiative, which we will fund through those first-year shared savings beginning in FY24. And then we will fund these through the completion of our waiver. And our waiver, as a reminder, it goes through calendar year 2030. So we're taking this first-year shared savings, and we are securing the funding of all of these items through the course of the waiver, which is 2030. So this initiative includes a number of really important measures. First, the postpartum coverage extension that I mentioned earlier, which is currently a pilot. We are proposing to make that permanent. We're also proposing to provide lactation supports and services for new mothers. We are proposing to increase eligibility for pregnant women, which we would raise the income cap for pregnant women. We are proposing to ensure 12 months of continuous eligibility for children. And then also we are proposing to increase the eligibility for parents. And this is important because it would close the coverage gap between the Medicaid limits and then the federal marketplace, where an individual can be eligible for subsidies, which would make those plans affordable. I do want to point out here that these items are funded on a recurring basis in the budget, and then we are going to essentially buy those back with the shared savings through the end of the waiver, which again is calendar year 2030. So this will avoid a fiscal cliff, and it will continue our practice of conservative and responsible budgeting, as we can't predict what the next waiver may look like. However, we think it's very possible, and we would hope that CMS would continue to see the value of this shared savings model and that there would be opportunities well beyond 2030. In addition, in the forthcoming budget amendment, as the governor noted in his State of the State address, we intend to provide for a pilot program where we will relieve a substantial burden of the cost of diapers for babies under 2 years of age, which, if approved, would make us the first Medicaid program in the country to provide this benefit. This is a first of its kind coverage. It would put real dollars back in the pockets of low income parents every month, to help them meet their other needs. While at the same time, we think that it will reduce the risk of diaper rash and urinary tract infections, which would help to decrease absences from early childhood education programs and reduced missed workdays for parents. The intent here is to cover half of a month's supply per child and to fund that on a non-recurring basis through the course of the waiver. All of these investments are made possible by this TennCare 3 waiver and the resulting shared savings. And they confirm, again, the collective sound decision-making of our state regarding our Medicaid program over the course of the last 2 decades. Now, it's important for me to stress that we just didn't get here. There was a lot of work by a lot of people over many, many years, different administrations, different general assemblies, different TennCare team members, and working with our partners and stakeholders. But at the end of the day, this waiver is good for Tennessee. It's good for the people that we serve. It's about improving health, which drives down healthcare costs, which will result in more shared savings, which we then reinvest back into the program to improve health. And so it's a cycle, and the intent is that this cycle will start all over again. And that's the beauty of this budget and what's possible in the future. While these investments are exciting and they're unprecedented, we will have the opportunity, you will have the opportunity to do so much more, because remember, this is just the first year of a 10-year waiver. This is the first batch of shared savings. We have every expectation that if we continue to do the things that we've done to get us here, that we will have these types of dollars available in the future. So I'll steal the words from the governor upon his reelection. We really are just getting started. I want to pivot to renewals because this is something that will have a substantial impact on our program and the people that we serve. We have not done this in quite a while. It's been 3 years, and so that creates some complexities for our team and for the people that we are serving. But I can say with every confidence that Tennessee is well positioned to go through this process. We are as prepared as we can be from a systems and a programmatic standpoint, and we are in a good place financially as well due to some very sound decision-making and planning by both the executive branch and the legislative branch. For some background on redetermination itself, this is something that is not new to us. It's not new to Medicaid. It's required by both state and federal law. It's a process that confirms continued eligibility for TennCare. It's a process that, absent extreme circumstances, is required each year, and we are prohibited from maintaining enrollment for anyone who does not verify eligibility requirements have been met. I mention extreme circumstances because we actually have experienced extreme circumstances, of course, over the last 3 years, which have thrown a wrench into this entire process. And of course, in January of 2020, the federal government issued a public health emergency in response to the pandemic, and that declaration included a continuous enrollment provision for Medicaid programs, meaning that the required renewal process that typically takes place every year, and therefore removal of anyone from the program due to ineligibility, has been suspended for the last 3 years. In late December of last year, Congress acted and decoupled the continuous enrollment provision from the public health emergency and set April 1st as the end of the continuous enrollment requirement, meaning that this process now must begin. As you would expect, the impact of the continuous enrollment provision is substantial. To date, we have increased our enrollment in TennCare by about 23% over pre-pandemic levels. That's more than 300,000 people. And so what this means is that in April or around April, we will have more than 1.7 million members that will go through the renewal process over the course of a 12-month period. And they're going to do that for the first time in 3 years. And some members will be going through that process for the first time since they've joined the TennCare program. So what happens now? As I mentioned earlier, we've been preparing for this for some time, not knowing when the public health emergency or this provision would end. We developed a 4-part plan that's focusing on planning, education, renewals, and then ultimately departures. And of course, each of those parts includes multiple components to better ensure clarity and responsiveness. I can say this without hesitation. It has never been easier to renew TennCare coverage if renewal is desired. I've said many times, including in this committee, that there's a dual responsibility here. There's a responsibility on the TennCare member who is receiving a first-class taxpayer-funded benefit to update the contact information and to respond to communication from TennCare. That is the only way that we can verify eligibility for most of our members and legally renew them. And then there's a responsibility on us at TennCare, and that is to make the process as easy and user-friendly as possible. And that is what we have done over the last few years, and that's what we continue to do. I hope when we get into questions, we can provide more detail on the 4-part plan. But for now, I'll say this. We have significantly ramped up our communication efforts with our members, as well as our providers and our stakeholders in an effort to notify members about what is about to happen and to ensure that we have all of the updated contact information. We've also strongly encouraged our members to open TennCare Connect accounts so that we don't have to rely solely on the physical address to communicate. In addition, we've taken advantage of one-time flexibilities provided by the federal government that will allow the maximum number of individuals to be renewed automatically based on other available data sources. The system really is designed in every way for members to maintain enrollment if they maintain eligibility status. And then for those that are deemed ineligible, we will transfer their information to the federal insurance marketplace where affordable plans exist for many. From a budget perspective, of course, our increased enrollment has large implications, but as I stated earlier, we are in a very good position to meet our projected obligations. As we have discussed previously with this committee, during the emergency, we have been receiving enhanced federal matching dollars to address the increased cost of membership. And per the recent action by Congress, this enhanced match will be phased down over the course of the next year. Our estimated non-recurring cost to cover the increased membership through this process is approximately $500 million. And the good news here is we have those funds in our reserve from the enhanced match. And again, we're well positioned to see this through. Before I wrap up my prepared comments, I want to highlight just a couple of additional items. First, we have another big proposed investment to support wage increases for our frontline direct service professionals. These are professionals that are working in our home and community-based service programs. That's item number 7. We also have a significant investment proposed for our behavioral health mobile crisis providers. That's item number 6. Both of these will build upon investments that you all approved last year. And then lastly, I do want to point to our trend number, which represents really the cost of doing business. This is inflation, it's utilization, it's membership. And I'll couple the pharmacy item with this because that's really trend as well. So that's items 2 and 3 on the list. Trend is historically our largest budget item. This year, it's larger than it has been in recent years, and that's not surprising considering that we are experiencing pretty high inflation. And what we are hearing, I'm sure you are hearing as well from our providers about the cost of operating, particularly the cost of hiring and retaining a workforce. Now, you may look at that medical inflation number, and your first reaction may be that it seems kind of low. It's about 2.4%. When I first saw it, I thought it was low as well, but that trend number also takes into account utilization. And the reality is that the increased costs of inflation are being partly offset by the fact utilization has not returned to pre-pandemic levels. So to put that in better perspective, if our utilization, if it were back to pre-pandemic levels, the trend number here would be triple what you see on the screen. So the impact of inflation is real. And when we talk about rate increases for our providers, these are the dollars from which those increases will come. The point being is that you don't have to see an individual line item for a provider rate increase for rate increases to occur. And typically you won't see those because that's handled through the managed care process and through the demands of the market. Okay, Mr. Chairman, I think that completes my prepared remarks. I'm very happy to address any questions that you or the committee
All right.
has.
Thank you. I do have a question. To start us off, how much, we have the shared savings. How much did we actually save the feds? And obviously with 300 million, the question was, what's the percentage that we saved them?
Yeah, so our portion, our total portion of shared savings is actually, it's 330 million. And now that's based on a percentage of the federal portion. So I'm gonna turn this, ask Zane to give you the total number.
Hello, Zane Sills, Chief Financial Officer. So as Stephen said, we drew down 330 million in shared savings. That's based off of a formula that's written into our waiver. That's based off of the amount that we underspend our budget neutrality cap. We underspent our budget neutrality cap in calendar year 21, which was the first year of the waiver, by about $1.7 billion.
Okay. Thank you. And then you'd spoken briefly about a fiscal cliff and the buyback. Can you go into that again? Because I think that's an important point.
Sure. So the total amount of the amount that we're projecting to spend with the shared savings is about $317 million. Everything except for the diaper piece is funded with recurring dollars in the budget that you have before you. And our intent is to take the shared savings dollars and buy those back every year from fiscal year 24 all the way through calendar year 2030. And so then when those dollars are no longer there, the recurring dollars are there to pick that back up. So there won't be that fiscal cliff. The diaper piece is a pilot. So that would go through 2030. And at that time, you all would have to make a decision about whether you wanted to continue that. And hopefully we'd have some results and to be able to show whether that was a positive thing for the state.
All right. Thank you. Yeah, that was what I was trying to get at there. Thank you. Representative King, you are recognized.
Thank you, Mr. Chairman. If you permit me, I'm going to ask about 3 questions. I guess firstly, a comment, Mr. Smith, Commissioner Smith. Of course, thank all of you for being here with us. But I guess a comment that you made, I want to start with that. Part of our responsibility is to ask questions and seek an understanding and the best way of providing services to our citizens. And maybe it's just my interpretation. It seems as though if you are questioned, that it's criticism. And I just want to let you know that I feel it's part of our role to ask questions. Okay. Now, my 3 questions. When it comes to increased access for clients and quality of service, I'm just trying to understand how we save $1.7 billion, do not decrease quality, and we increase access. I'm just trying to understand how we do that. Not the whole picture, but an example.
Sure. And Representative, I apologize. I certainly didn't mean, I wasn't referring, when I talked about criticism, I wasn't referring to any particular individual. Certainly wasn't referring to anyone on this committee. So I apologize for that. So the issue about the savings, and this really gets into the weeds, but we have an 1115 waiver with the federal government, with CMS, and there are many states that have this type of waiver. And when a state enters into an 1115 waiver, it has to commit that it will not spend any more dollars than it would have spent absent the waiver. Because the idea is you're going to innovate, you're going to try some new things, and ultimately what you're hoping to do is that you will do that more efficiently and more effectively. And so when you negotiate those 1115 waivers, there is a budget neutrality cap, and that budget neutrality cap is designed to be at a level where you would be absent the waiver. And so then over time, you actually see what you have spent, and then that gets compared to your budget neutrality cap. Now, We negotiated a very favorable budget neutrality cap for Tennessee. That was part of the negotiations. And when we said that it was very important for us that we were not going to negotiate a deal that didn't have Tennessee's best interests at heart. And so we were able to negotiate a favorable budget neutrality cap that also had a very favorable trend rate that we get an adjustment every single year. But it doesn't mean that, it doesn't mean that we're making cuts to the program. It just means that over the course of time, we are spending less than what we've negotiated in the waiver would be the amount if we didn't have the 1115 waiver. I know that gets very confusing. We take a lot of issue with how the budget neutrality cap actually gets set. But by definition, that's kind of how it works.
You're recognized.
Thank you, Mr. Chairman. My second question is in regards to, I believe you said a survey that clients or members fill out. I'm just thinking, if I'm a person on, dealing with TennCare, I would not be inclined to, if there was a negative piece of service that I had, I wouldn't be necessarily inclined to let you know about that, because I'd be afraid that some kind of way I'm going to get cut off. And I guess what I'm asking is, beyond the fear factor, do you of that what I just described, do you feel that these are the true sentiments of the clients that turned in their surveys?
I do. I appreciate the question. I do think it represents the actual sentiments of the members, because we've seen great consistency over the course of 10, 15 years. And it used to be a lot lower. You go back before those 15 years, those 10, 15 years, it was a lot lower. And so we've improved pretty considerably. The other thing to point out is we don't do that survey.
Mm-hmm.
The survey is not conducted by TennCare. It's conducted by the University of Tennessee. It's completely confidential. We never see any of the identifiable information.
Okay. All right. One last question,
You're
Mr.
recognized.
Chairman. It's been, I guess, talked about that I believe 25,000 more clients or citizens were put into the system as a result of the savings that we received. And I think that's wonderful. But are you of the same mindset or understanding that we have 300,000 to 400,000 people who may not be receiving services at this time because of, I guess, the type of plan that we have?
Mm-hmm.
And how do we get more people into the system? I guess what I'm getting at is, I think it impacts employment, children going to school, women going back to work, and things of that nature. So if you give me a perspective on that.
Yeah, I appreciate the comment. I think that's a much bigger discussion. It's a bigger policy discussion. I think you're referring to expansion under the Affordable Care Act, and I know that that's an issue that's been before this body before. And so there is a question about whether that's something that you all believe the state should do. All we can do at this moment is focus on the population that is eligible today. And what we're proposing to do with the shared savings is to really serve the traditional core population of a Medicaid program and focus on families, so children, pregnant women, and parents, versus the expansion population is primarily childless, working age adults. But I certainly understand the policy debate.
All right. Thank you, Mr. Chairman, and thank you.
Thank you. Next on our list, Representative Clemens.
Thank you, Mr. Chairman. So with regard to the redetermination, according to reports, roughly 1/5 of the 1.7 million Tennesseans covered could lose coverage. Are y'all still using the hard form U.S. Postal Service redetermination process?
I'll let Kim answer that, but I want to point out one clarification. So we actually don't know how many people will be removed once we go through this process. It's all going to be dependent upon eligibility and response. We were asked to give our best projection, and so that's what we've done. And our best projection is that we will be back to our pre-pandemic levels, which was about 1.4 million. And one of the reasons why we say that is because we were still trending down in enrollment prior to the pandemic. So we never really reached that normal status. But I want to clarify with the committee that we actually don't know where we will ultimately end up. But I'll refer to Kim Hagan, who is over our member services, and she can give you a lot of the detail about all the improvements that we've made over the last couple of years.
Sure. Okay. Thanks for the question. Kim Hagan, Director of Member Services. So this time around, members can choose many different ways to complete the redetermination process. For every monthly cohort, the first thing we'll do, and Stephen referred to it a while ago, is run an ex parte auto renewal process to see how many people can we just reapprove using the data that we have available to us. And we've taken advantage of some one-time waivers, including using SNAP and TANF data. So, for example, if you're in a child category and your family has open SNAP, we'll assume that you continue to meet our income criteria, and we'll be able to auto renew you. And then you'll just get a letter saying you've been auto renewed, and you'll continue receiving coverage. For those who cannot be auto renewed each month, we will send a pre-printed renewal packet, and we'll send that either via mail or electronically if they've set up a TennCare Connect account and chosen to receive electronic communications. We will then the person will be able to complete the renewal process various ways. They can go online through TennCare Connect. They'll be presented with all of the data we have on their family. They'll just be able to flip through screens, make changes for anything that needs to be updated. They can call our TennCare Connect call center and complete the renewal on the phone. They can mail it in if they choose to. It will be pre-printed, and they'll just have to, mark out anything that has changed for them. We still have faxes if anyone wants to use a fax, or they can go to any DHS county office and drop it off there. Then, if we need additional information, let's say we need proof of income, our data sources can't give us that proof and we need proof of income, they can use all of those same methods. But then we also now have a TennCare Connect app they could use to take a picture of, let's say, a pay stub or whatever we've asked for that will automatically upload to their account.
You recognize?
Thank you. That's good to hear. I mean, I think the Pasture Alliance, and I know there's ongoing litigation, I think, about the unenrollment of individuals in the past. That's my understanding, because it was so complicated. So I'm glad to hear that y'all are evolving in that respect. I am curious, when was that budget neutrality cap approved?
That would have been when we got approved the waiver. Yeah, so January of 21. Yeah, sorry, it would have been January of 21.
January 21. So that would have been approved by CMS under the President administration, correct?
That's right.
So it seems like we got a favorable budget cap there because there's an interest in the federal government in us covering as many individuals as possible. Is that a fair statement?
Well, one thing I should point out is that there's an adjustment for any new individual that comes onto the program, and so there's no disincentive to bringing new people onto the program. With the previous administration, we got an adjustment for any enrollment increase above 1%. Now, of course, this administration they had some concerns with the waiver, and so we have submitted an amendment to the current CMS administration. And one of the things that they wanted us to do, which was just to have a per capita adjustment, which means that you could kind of take away the 1%, and any additional individual that comes onto the program, we would get an adjustment on our budget neutrality cap, which is actually more beneficial to us. And so we agreed to that.
Yeah,
You recognize?
yeah, it just seems like, I mean, we're fortunate that this administration, this presidential administration gave us such a generous budget neutrality cap. And because of that, I mean, it makes the state look better. I mean, that's our savings are bigger because of that neutrality cap, right?
Well, let me just clarify, because the January approval was the prior administration. So our initial budget neutrality cap was approved under the prior administration. And now we've had some additional discussions with the new administration about not necessarily the cap itself, but how the cap gets adjusted when new members come on.
So if we're comparing apples to apples here, or maybe you may consider it apples to oranges, how many billions did we turn away by refusing to expand Medicaid since 2014?
Representative, I don't have those numbers.
I mean, from a budgetary standpoint, you don't know how many billions of dollars that we refused to accept from the federal government?
I haven't done the math since 2014. I could tell you what the numbers would look like if we did that today, and what the cost would be.
So in 2014, how many was it on an annual basis?
2014, I don't have those numbers. I wasn't at TennCare in 2014.
Okay, I'm just trying to get an idea here as to what the decision making of this state looks like from a fiscal perspective, since we have a fiscal duty to taxpayers who have paid their hard-earned money into the federal government, and we've turned those dollars away, and now we're talking about savings, which are fantastic, but we're talking about approximately $300 million in savings compared to billions of dollars that we could have received and invested right back into the program and covered more individuals that my colleague from Hamilton County was discussing earlier. So I appreciate your response. Thanks.
Thank you. And we've got more people in here. To his point, if you can get to my office and maybe to the members of this committee, of any of the population, how much we pay per population, per person on enrollment. If you could give us that number, that'd be great. So how much it costs per
Just-
enrollees?
Just kind of an average
Yeah,
of the.
average cost.
Yes, sir.
All right, thank you. Chairman Williams, you recognize.
Thank you, Director Smith. I appreciate you coming here today. As we talked in the hall, I guess, earlier in the week, would love to still see a deposit slip with $330 million. Since we're talking about administrations, I'm not sure I really believe it till I see it. I do think, and to my colleague from Nashville's point, this legislature, along with your help and the governor's help, saw the opportunity to do a block grant that what we're saying is paying dividends for us, which is going to give us, even in your budget, you said the hope was to spend this $330 million savings on growing services for Tennesseans. And even your plan does that, I think. And so for that, I'm very excited because we did have some states to the north of us who did expand Medicaid, and they're running billions of dollars of deficits. And so to you and your staff, you'll be commended for the work that you're doing. I did have one concern, though, because this is the first year of those savings, and we're going through redetermination, and we're, by your testimony just a minute ago, you said, we're not certain how many people are going to qualify. My only fear would be, I want to provide more services, and I think the majority of the people on this committee want to provide more service to Tennesseans if we can. But are you at all concerned about what happens if we commit to providing additional services in this coming fiscal year, and maybe the rate of return is less than what we saw this year? How comfortable, I guess, are you that if we did grow those services in order out of that $330 million, will we be able to do it next year and keep the promise to those that we provide these services to?
Yeah. Thanks for the question. Two pieces there. I mean, I do have some concern about what our enrollment's going to look like once we get through the process, because there is a lot of uncertainty there. The reality is that if we're in a different place than we think we're going to be, the shared savings is not really the dollars that are going to be able to address that. We'd have to come before you and ask for recurring dollars to address it. The other piece is that part of the commitment in the waiver was that we would take the shared savings dollars and enhance benefits and services or serve additional people in need. And so that's why when you see the proposals, it falls within that category.
You recognize?
Just to jump around a little bit, I noticed in line item on, I think the one before that page, they had the pharmacy benefits, I think line item 3, that number as it relates to pharmacy. When you look at the total expenditures in any of these line items, do they accommodate, or is any of those numbers have to do with services as it relates to COVID? For instance, would that have vaccines in that, or are those numbers for TennCare patients completely separate? I guess what I was trying to figure out is, are those monies segregated somehow, or are they intertwined?
Yeah. So initially, for the first couple of years, we had all of those dollars, testing and vaccines and all of that was kind of isolated as non-recurring, but we've built that into the trend. So that would be included now in the recurring numbers.
Okay. So would it be, and I'm picking on this line item, but it could be any line item, but is it your expectation, as the president says, we're coming out of this emergency, that in some areas, because, the COVID monies are kind of cooked in, that you would see some of these reduce, which would help with your concern and inflation going forward, or no?
Potentially, but I think the amounts are, in the grand scheme of things, are probably pretty low, but maybe I should let Zane speak to that. Okay.
Yeah, and also I second that. And also what I would say is, because the COVID enhanced funding from the federal government, there were several streams of that, right? Because that was all non-recurring, we treated it as non-recurring from the very beginning, and we never baked it into the recurring assumptions of our budget, because we did not want to create a fiscal cliff for the state, because we knew those dollars would go away at some point.
Okay. Thank you.
All right, thank you. Representative Mitchell, you recognize?
Yeah, thank you, Mr. Chair. So with this savings on the block grant, how many people, new enrollees did we add?
Well, our estimate is that we would be adding 25,000 additional.
So you haven't as of yet.
Well, no, we don't. The budget hasn't been approved yet, so we have not as of yet.
Okay. So now we're up to 39 states that have expanded. So which is greater, 66 or 90? Which is a larger number?
90?
Okay. Well, or 72. You're getting 72 right now, that it's about to go back to 66 cents on the dollar.
Mm-hmm.
So we've got 150,000 Tennesseans sitting out there that right now could have medical coverage, and the state would be getting 20% more from the feds with the 90 instead of the 72. We're going to increase the rolls up by only 10%. But we're going to get 20% more money. I think the Kaiser Foundation, instead of 300 million, you'd be sitting on 900 million more. So, I mean, I don't know. It seems like, it reminds me of the parable of the three servants. We've been giving, something to take care of. You've been given your one bag of silver, and, the states around us have been given, their 2 bags and 5 bags, and they've turned them into 10. And you're sitting here saying, we might, be able to add, a small fraction of that 150 to 180,000 people that need health coverage, and we're acting like it's a success. to those 180,000 people without health coverage, it's a failure. I'll let you know that. They think it's a failure. So we're at least $600 million down from what you're calling a success, and at least 125,000 people down. So I don't know what the problem with this state is, that we can't figure out basic math. 90 cents on the dollar is greater than 66 cents on the dollar. Thanks.
Thank you. Chairman Hawk, you recognize.
Thank you, Mr. Chairman. I'll take folks back to slide number 5. Could you put that back up for us, please? The original plan of TennCare itself, back in the mid-90s, was to essentially serve 1 in 6 Tennesseans. Tennessee's population at the time was roughly 6 million people. We were serving roughly 1 million people with TennCare services at that time, as folks were being enrolled onto the program. As you look at the figure at January 20 on the slide there, we were at 1.4 million Tennesseans, which was closer to 1 in 5 individuals across the state of Tennessee who were being served by the TennCare program. At the peak of the COVID timeframe, the high spot on that slide, you'll see we were close to 1.8 million people, which goes to almost 1 in 4 Tennesseans were under the TennCare program. So the potential is, and as Director Smith has very clearly pointed out, we don't know exactly what the disenrollment is going to look like. We're just using historical data from eligibility attainment from citizens, that we go back to that 1 in 5 Tennesseans being served by. So that's the reality of what we're looking at there. And I've mentioned this before in Finance Committee. Before the headline reads that TennCare disenrolls X number of folks, there's an eligibility requirement that is met, and this is the reason why we're looking at that. As we're talking about the shared savings plan, and yes, it was approved in the last few days of a former executive administration in Washington, but has been validated in the last few days by a subsequent administration, by the input of $300 million coming back to the state of Tennessee, which I think is critically important to recognize that CMS is looking to Tennessee for us to make this work. And they feel like we have put forth a good plan, both in January of 21 and through the negotiations in January of 23, that they're looking to us to fix the national level. And we are a microcosm of what the health insurance as well as the healthcare industry can look like in the days to come. So I'm very encouraged by what you have put forth and what we are seeing from 2 different administrations now who want to see the success. And it looks like they're investing in our success. So thank you very much. I want to talk about some of the potential dollars. We can talk about potential dollars drawn down and what that might have looked like. Director Smith also said earlier in your comments that we were at a point in the Bredesen administration that 91 cents of every new revenue dollar coming into the state of Tennessee was about to be absorbed by TennCare spending. So we had to get that under control. And that's when we made the painful cuts that Director Smith had mentioned just a few moments ago. That was hard to do. And we've done everything we could to set up safety nets at our health departments. We did everything we could to set up our county health departments to ensure that we had a safety net there in place. We put primary care in areas. Now we're expanding that even more to the postpartum care for mothers and children. We're expanding that to adult dental care. And we're doing it in a fiscally responsible way. In order to draw down some of those dollars that have been discussed in this committee earlier, yes, there's a substantial amount of money that is dangled in front of you, but there's still a state investment that has to come about. you can offer me $1 billion all day long, but if I have to put up $100 million to get that $1 billion and I don't have $100 million, it really doesn't matter. So you have to look at what you're going to cut, what $100 million you're going to cut in order to draw down that $1 billion. And we have to be fiscally responsible in the other $55.6 billion within this budget document in order to make good, sound financial decisions going forward, which is why now we've heard from the comptroller and many other folks why we are considered one of the best financially managed states in the country, largely because of the way we manage this budget that Director Smith has put forth, as well as other budget documents with other departments. So I say thank you for the work that you've done. Happy to answer any questions my colleagues may have on that as well. Thank you, Chairman and members.
Thank you. You good? All right, Representative Hemmer, you're recognized.
Thank you, Mr. Chairman. I believe you did a RFP in the last year for around, I believe it's the Social Determinants of Health Network or something called similar to that. Can you provide an update to that?
We did, we had an RFP for, you're probably referring to the closed loop referral system.
Yeah.
Which was related to that. We had a protest. We had to re-procure that. That's in process right now. And so I actually can't talk about it.
Thanks. Secondly, you mentioned your 11115 waiver, and found interesting in my research a few other states such as Arizona and Oregon have done similar waivers around transitional housing programs for individuals who are homeless, risk of homeless, transitioning out of emergency shelters, youth transitioning out of foster care, et cetera. Found it very interesting, and was curious about these are very complex medical conditions that these patients have, very expensive to manage. So just kind of curious from what similar strategies that TennCare is putting in place to help and specifically provide housing to these specific type of populations.
Yeah, glad to do that. We actually have a Health Starts program that you all funded last year. You started a pilot, and we're very excited about that. I'm going to let Dr. Wu talk about that. I will say that housing is not part of that. We haven't gone down that road. We're instead, we're focusing on different pieces of that. And I'm going to let Dr. Wu speak to that.
Great. My name is Victor Wu, Chief Medical Officer. Representative Hammer, thank you for your question. We're really excited about the work around health-related social needs, or otherwise referred to sometimes as social determinants of health. Housing is certainly one of those types of social determinants of health, but there are many others that have a direct and outsized impact on individuals' health, which include food security, transportation, access to support services. One of the areas we've been focusing on with the Health Starts funding that's been provided us is really connecting members, TennCare members, directly to resources that already exist in the community. There are a lot of community organizations, nonprofit groups, faith-based groups that are doing a lot of tremendous amount of work in this space. And oftentimes our members need those services, and to find a sustainable pathway to do that, we've been partnering with our health insurance companies, as well as our health providers, whether it's hospitals or primary care providers, behavioral health providers in the community, to really identify these social support needs, connect them to existing services in their community, and making sure that those referrals actually get completed so that our members can find a sustainable path to accessing service and ultimately, hopefully, move toward more independence when needed. So these are some of the types of things. Housing is not a direct investment that we're doing. However, we're really taking advantage of existing supports around housing in the community, connecting individuals to housing supports, housing counseling, rent support systems as well. And so that's in our radar and something that we've been working on in partnership with our health plans.
Great. I think
Representative Hammer,
it's a
you're
great.
recognized.
Sorry.
You're recognized.
Okay, thank you. Thank you. I think it's a great start. It's a really good program to start with, but I'd urge you to, as you go to your Medicaid conferences, talk to your other directors and peers to really understand how these programs, you have two states on the opposite end of political spectrums that are both, undertaking this issue directly with housing. And we all know the impact this has specifically in those type of populations. So would love to understand better how, what are working in those states, as well as other best practices that are done around this issue in the future. Thank you.
All right. Thank you. Any further questions while we're out of session? Okay. Seeing none, I'd like to thank you for your presentation and obviously thank you for your time. And so it's a pleasure when you come by and particularly when you come by our office and have some some of these real deep discussions that we do have, and look forward to talking with you more on these issues and getting some of those numbers. But thank you so much.
Thank you, Mr.
So-
Chairman and members.
All right, without objection, we're going back into session. Before we adjourn, I just would like to remind everybody that next week we will have the Department of Health for their budget presentation. We will start off the committee with Department of Health. So seeing no further business before us, we are adjourned.